Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Left Main Bifurcation Lesion Preparation before stenting with cutting balloon. This is my disclosure slide, and I'll go for next one. As you see here, there is a case example, female 75 years old with stable angina, class 3 and previous PCI for mid-LID with BMS. I will tell later on why there is a BMS, because actually this is a case which done more than 10 years ago. And why it is important, because actually around 20 years we do cases like this. And we have experience with several thousand left main cases with lesion preparation. Risk factors: hypertension, diabetes, dyslipidemia, and comorbidities: atrial fibrillation, left ventricle ejection fraction 60, and 6 syntax score 23. As you see, the syntax score is not so high, but it is the usual its usual story about isolated left main, because as you know, left main itself not actually giving us a very high syntax score. Nevertheless, it doesn't mean that left main intervention is always very easy and not request from us real skills and understanding what we are doing. As you see here, it seems very well how it looks like. It's quite long left main body, and then you see there is a lesion what we call 111. And for this reason, what we should do and what we recommended, is also recommended in EBC guidelines, and not only that, what we need to use imaging. If you look on imaging, then you see in different here you see very well LID and also the circ. And as you see here, there's a real calcium which we need somehow to prepare for a good stent expansion. Also quite interesting is that at that time we always look on bifurcations, and it's not except left main bifurcation that it's best way how to treat is to use one stent strategy. And of course, now we maybe know a bit more about that, how we use culotte stenting, or how we use crush stenting, or it's a new approach about double crush stenting. But as I said years ago, we really, and it's still important to understand that we prove the one stent strategy. But of course, again, in other cases we can't fix this if we use only one stent, and we need to prepare for also for second stent. But in this particular case, we really thought that maybe we will be happy with one stent. And as you see here, how it's done. First of all, it's wired both branch, left main and left main LID, left main circ. What we used transradial approach, 75 years old lady, radial approach, and 7 French guiding catheter. Sometimes people are saying that it is too big. In our practice, as I said, there's not one case, there's thousands of cases. Actually, usually radial arteries accepted this 7 French guiding catheter. And then we use cutting balloon 3.5, in this particular case 6 millimeters in both branches, in left main LID actually, and left main circ. After that, you see how it looks like. It's completely different, and this is important because there is a dominant circ. It really depends on anatomy how we can deal with fixing the lesion. There is a dominant circ, and as you see, there is now it's completely different flow, and also the lesion looks very nicely smooth. That means that actually we really prepared plaque already. But after the first stent implantation, as you see, drug-eluting stent 4.0, 20 millimeters, 13 atmospheres. As you see, after stent implantation, there is some pinching of sac. For this reason, we use kissing balloon, but after kissing balloon is still the residual stenosis, and then we use, which is not often used, is T-stent implantation, and we use the drug-eluting stent 3.5, 8 millimeters, and kissing, final kissing, and even in that time we use a pot, and this is after final kissing and pot procedure. As you see here, there is seams how it looks like in spider view, and now it's a both branches flow is not flow is really good. It's TME3, and also if you look here, also angiographically, it looks nicely. And this is a post-intervention IVUS. As you see in post-intervention IVUS, there is a very good apposition, stent apposition. The symmetry index is okay, and stent implanted in good manner. And now I want to show you how it looks like after 10 years. And this is from our practice what we see, that if you do good stent lesion preparation, if you do good stent expansion with proper post-treatment and imaging, the results are really good. And as my favorite, picture, it's Leonardo Gioconda, then you see that it's really important to be focused on details, but we still need to look on pictures. And thank you very much for your attention. Yeah, no, about left main, it is, again, I can, of course, we participate in practically in all left main studies, left main versus CABG, like started with Syntax and then Excel, Noble, EBC main, and also we have around 4,000, I guess even a bit more, left main interventions in past 20 years here in our institution. And it is quite interesting, because you ask about that, and I'm now preparing lecture for this great wall conference, and they also ask about, for example, if surgeons refuse patient, and we have a right coronary artery closed right coronary artery occluded, and we have just like one vessel, which is a left main intervention. And I agree that I guess that from studies we can't answer that. We have no data about. But what we can do this like experts. And I'd say that's why I always try to use very simple way to treat left main, even distal left main, because the left main, actually, it is like Anders Grunzig says, that probably the left main will be the best option for interventionist. Of course, at that time he didn't mean stent implantation, because he did only balloons, and then the answer was because it's a big diameter, as Holger mentioned, that we need to always know the diameters and vessel dimensions, and this is very proximal. That's why I guess that the most important for left main is how quick you can do that. But on the other hand, I completely agree that it's very often this is a challenging lesions, and maybe it's really also very important anatomy of coronary circulation. Is it dominant circ, or it is dominant right, and how we can protect, and this, of course. And why I'm talking about that, because depends on this, I guess that we can find the cases, specific cases with low ejection fraction where we can support. And I remember very well then we at least always to put a sheet in femoral artery in case if we will go wrong. And also we did this comparison between, at that time, balloon pump
intervention and no balloon pump intervention, but at least in our hands there were no difference. Another, but of course, I guess that in specifically difficult cases we can use, for example, Impella, and at least we will be much more calm and we preserve maybe our minds more. But this is, I guess, you know, 1 from 200 cases when we need to do that or something like that. Yeah. I'm not sure that we can this to support by no, but this is also the question for me, because you know I did around not so many lithotripsy cases, but I can imagine that maybe the lithotripsy behavior in left main could be different from what we use in past. For this reason, I guess that maybe it would be very interesting to hear something from operators who really try that.
Well, I have done many cases with IVL in the left main, and of course, as always mentioned before, rod ablation or the rotational atherectomy is only using one wire, and you will lose automatically one wire if you want to go for LAD, for example, or circ. So this is what we can completely abolish, or we can reduce this risk of losing a side branch, because we can use both guide wires to perform the IVL. And of course, this is, I think, one of the biggest advantages coming along with the IVL.
Holger, may I ask you, this is very, very interesting, and may I ask you about how you choose size of balloon for left main? I mean, if you use IVL.
Well, of course, this is also coming as an information which comes from the intravascular imaging. And of course, as always, as also you perform left main, we have to use, is also a guideline a recommendation 2A, and we use the intravascular imaging for left main, and the information regarding the vessel dimension comes from the intravascular imaging. And of course, we orientate on the distal reference vessel diameter, of course. And this is, I think, the way to go. And if we have a large difference between the vessel diameters, you have to choose, of course, most probably 2 IVL balloons.
That means that I'm really sorry. I understand we should move, but it is a really interesting topic. That means that, for example, if we have a real 1-1-1 lesion from ABC, I mean calcification, then you use two IVL balloons, one in LAD and maybe a different size on circ.
Well, in the most cases, 90% and more, we have 2 equal sizes in LED and circ, and we can use, of course, 40 impulses for the circ and 40 impulses for the LED. And I have used twice a time 2 balloons for the left main, but this is very rare because the main problem of stent expansion happens not in the distal left main or shaft left main. The main problem exists in the ostial circ or ostial LAD, and that's the region where we can most affect the plaque morphology with the IVL balloon.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Orbital Atherectomy for Treatment of Severely Calcified Coronary Artery Bifurcation Lesions. Management of bifurcation lesion presents a challenge to interventional cardiologists and are associated with high rate of procedural complication and long-term MACE. Optimal plaque modification is most important step prior to stent deployment in calcific lesion. Safety of coronary orbital atherectomy has been supported from previous Orbital trial that led to FDA approval. Low risk of MACE with the OA of use of OA in bifurcation lesion has been shown by us as a single center study. So this is a case of a 51-year-old male who presented to an outside hospital with non-STEMI 2 days prior. They had a cath there, had significant LAD disease and a known old total circumflex disease. He was transferred here for high-risk PCI. Known hyperlipidemia, smoking, controlled hypertension, had no prior known cardiac history otherwise. On medication of Lipitor, low pressure aspirin. So cath had shown significant LAD diagonal lesion and a total occlusion of OM1 with a syntax score of 22, EF 55. So the plan was to do an OCT-guided PCI of calcific LAD diagonal lesion using orbital atherectomy. So this is the angiogram, mid-LAD, significant lesion involving a moderate size diagonal, which also has some significant disease. We saw it in 2 views. So this is orbital atherectomy, OA, before we see that there is calcium arc of 180 degree with the maximum thickness of 0.7 millimeter of the calcium. So we did a orbital atherectomy, 80,000 RPM for 60 seconds or so with a wiper wire. So as soon as we did our orbital atherectomy, you see there definitely is a slow flow in the main vessel. So to rule out the dissection or so, immediately go with the balloon and then give a lot of vasodilators. Subsequently, we wired the side branch with a fielder wire and we had a run through in the main vessel. So we had to remove the wiper wire of the orbital atherectomy. Despite that, the flow got better, but you see some dissection now in the LAD. So with the 2.2 balloon, we dilated the side branch, and then also we dilated the main branch. Since the side branch had disease and moderate size, we decided to go with a dedicated 2-stent technique. We use a mini crush stenting technique where Zions 3538 was used in the main vessel and Zions 2.15 millimeter was used in the side branch. Final kissing balloon, and this is the final angiogram, which shows excellent result with a good flow. This is the final OCT, which shows no edge dissection as well as a good malopposition of the stent in the main vessel. So just to show you orbital atherectomy, rotational atherectomy, everybody knows what how these devices work. One has eccentrically mounted diamond chip and rotational atherectomy has it at the tip. So we were the first one actually to use orbital atherectomy in calcific bifurcation lesion in a small group, and we showed that it is feasible. We were the part of a large multi-center registry for orbital atherectomy for treatment of severely calcified coronary artery bifurcation lesion. It was a multi-center analysis that got published. So if you see here, OA both in bifurcation and non-bifurcation, that in bifurcation lesion, the dissection is slightly higher. Perforation embolization was comparable to non-bifurcation lesion. So when you go to propensity scored match, what we saw that 30-day outcome was equivalent in both bifurcation as well as non-bifurcation lesion with statistically no difference between the two. So this registry actually included larger and more complex patient population compared to the original Orbit study, but 30-day MACE was comparable to the Orbit study. We were the first one also to show the mechanism of action of orbital atherectomy. So what we, when we did imaging, what we saw was a calcium arc was the key factor, that if the calcium arc was bigger or a larger arc, then your type of dissection, which is type A, type 2, dissection or cuts were smaller. When you had a smaller arc, then you got a deep intimal dissection, which we called it as type 3. This is the deep cuts that you see here with the OCT, calcium sanding when you do OA, and as well as the calcium cracks that you see when you do OA. So just to see how can we take care of this calcific bifurcation lesion, always we decide whether it is left main or non-left main, and decision of calcium can be made based on angiography or imaging. So if in the main vessel, which of the left main, that if you have moderate calcium, consider just cutting balloon, severe calcium, you can decide any kind of a atherectomy that you want to do. If the side branch, which is usually the large vessel circumflex or LAD, has moderate, you can do cutting balloon and decide on and has significant lesion, do two-stent technique. But if the side branch has severe calcium, you may have to do atherectomy, even atherectomy also of the side branch, and then do two-stent technique. So for the non-left main, if you see, for the main vessel, same. If you have moderate calcium, cutting balloon. Severe calcium, do OA, IVL, or RA. If the side branch is large and you have a more than 70% diameter stenosis and the lesion is longer, also you can consider a rotational atherectomy, OA, IVL, and then do two-stent technique. So how to take care of calcific lesion? We actually have a calcific app that is free to be downloaded. We tell you the various techniques, how to do orbital atherectomy, both for bifurcation, non-bifurcation lesion. Various apps are available on cardiologyapps.com. This was a Bifurcate 3D app where we are showing animation how to do a bifurcation technique of whatever kind of technique that you want to learn. Here we are showing a mini crush technique. So just ladies and gentlemen, to conclude, the goal of bifurcation PCI is to achieve optimal result in main vessel and maintain physiology patency of the side branch. Provisional side branch stenting should be the default technique, that provisional stenting should be done. Two-stent technique might be preferable for a large side branch with greater than 70% diameter stenosis, or you have a long lesion greater than 10 millimeter. Imaging to predict any complication should be considered. So if you have severe calcium, optimal preparation of the main vessel and or side branch using various devices, whether it is orbital atherectomy, RA or IVL, is safe and efficacious in treatment of bifurcation lesion. And thank you for your attention. These are the various apps that are available on cardiologyapps.com. These apps can be downloaded free and for interventional cardiologists. Thank you.
Well, thank you for the question. The advantages of IVL is, I think, a little bit explaining from the limitation of rotational atherectomy or other debiking devices itself. If you look at the definition, which means when we are going to speak of a very calcified lesion, so we know from the data so far that if there is more than 180-degree circumferential calcium, if there is a calcium thickness of more than 0.5 millimeter and calcium length of more than 5 millimeter, we have obviously problems to dilate this lesion abruptly. So in these cases, we have, of course, the option for rotational atherectomy. But if you look at large vessel, for example, if you look at eccentric lesions, eccentric calcified lesion, and if you look at torches or bifurcation situations, so there are some limitations coming around with the rotational atherectomy for this kind of lesions. I think IVL offers a perfect option, an alternative to treat these stenosis in a very adequate way. So, of course, IVL is not a procedure which is obviously in a daily practice a priori, but we have the possibility to choose between these different debiking devices. And of course, we have some clinical situation where IVL should be used upfront.
Actually, for me, it's always a bit a question. We do with plaque modification we discussing this around 20 years, even more, and maybe before when we started in balloon angioplasty, of course, etc., which maybe meantime interventions even can't to remember. But for me, it's always was the question how you decide and how you can really understand that we need to use one or other, plaque modificator. I don't know if we can call that or not. And for this reason, I was a bit skeptic in past and also in nowadays. Do you think that we always should use imaging before we start to use one or other device, or we can use other predictors, and then we need to understand which predictors we use if we decide and choose one or other device?
If it's a question for me, so I think that we, of course, do not have any other parameters so far as the intravascular imaging. So we have no parameters from the angiography coming, which shows us that IVL could be an alternative option to the ENC balloons, for example. So by so far, we do need the intravascular imaging to decide whether we have to go for a rotational atherectomy, for example, or for the IVL, because what is difficult for the until now used debiking plaque modifying tools. So the problem is that we nowadays want to know whether the calcification is eccentric or concentric. We want to know whether the calcium plaque is deeper than 0.5 millimeter, and we want to know what is the length of the calcium within the stenosis. And these are very interesting parameters which leads us to the decision which debiking device we have to use. I think also we can get the information from the intravascular imaging, how large is the vessel, which is also sometimes a limitation for rotational atherectomy, for example. And I think taken together, intravascular imaging from a nowadays standpoint, we should use to decide which debiking device we have to use.
Dear Chairman, thank you for the invitation to participate in the European Bifurcation Club 2021. I'm Alfonso Jurado Roman from La Paz University Hospital of Madrid. And the title of my presentation is Bifurcation Lesion Preparation with Rotashock in Bifurcation Lesions. I have taken the liberty to change a little bit the title, as we prefer the term rotatripsy, as it was the term we used when we first described this technique. The clinical case is about a 74-year-old female with several comorbidities, diabetes, hypertension, lupus, previous renal transplantation, who was admitted in our hospital for a non-STEMI episode. The left ventricle ejection fraction was 40%, and she suffered from peripheral artery disease, very severe artery disease with impossibility for radial or ulnar approach, and also with severe femoral disease. This is the first angiography with a calcified nodal distal left main and a critical lesion at proximal mid LAD that produced a TIMI2 flow. The patient was stable at this point. So in summary, we had two bifurcations in series, one at the distal left main with a calcium nodule, 100 of Medina, and the other one at the proximal mid LAD with some affection of the diagonal branch, 111 of Medina, but the diagonal branch had 1.52 millimeters of diameter. So we decided to perform the PCI without any left ventricle support because of the peripheral artery disease, with femoral approach, EBU 4-7 French. And we could cross with some difficulties to LAD with a cyan black wire over a fine cross microcatheter. However, the fine cross could not follow the wire, and we couldn't use it to exchange this wire and change for the rota wire. So we predilate with small balloons, and this is the angio after predilatation. We improved a little bit the flow, and we could observe better the calcium nodule at the distal left main protruding at this point, without significant impairment of the ostium of the left circumflex. So we follow with the initial strategy, the rotatripsy, advancing the rota wire through the fine cross and performing a rotational atherectomy with a 1.5 bar. We knew that rotational atherectomy wouldn't be enough to ablate this calcium nodule, but it was necessary to deliver the shockwave balloon. So after rotational atherectomy, we used a 3.5 shockwave balloon, and we applied 80 pulses at distal left main and proximal LAD. Before these pulses, before lithotripsy, we protected the side branch, the circumflex, with another wire. That, as you know, is one of the advantages of the lithotripsy against rotational or orbital atherectomy. This is the IBUS after rotatripsy with some intimal ablations and deep fractures produced by rotablation and shockwave. And after that, we decided to post-dilate with a 3.5 NC balloon at height atmospheres. After that, we implanted two overlapped drug-eluting stents at distal, at left main and proximal LAD. And after that, we performed POT, an aggressive POT with a 4.5 millimeters balloon according to the measurements in the IBUS. This is the final result in the angiogram. And this is the measurement in the IBUS with a 10 millimeter square area, minimal luminal area at the calcium nodule. So in summary, we think that rotatripsy, the combination of rotational atherectomy and intravascular lithotripsy, is a great technique when you have severe lesions, and deep calcium, because a rotational atherectomy is needed to create a tunnel after intimal ablation to deliver a shockwave balloon that cannot cross if the stenosis is very tight. And we know that rotational atherectomy cannot ablate deep calcium, that also only performs intimal ablation, and shockwave does it. So this is how we reflect this combination of effects with intimal ablation of rotational atherectomy, as you can see here, and deep fractures of shockwave. So this is, we have published the first series of this technique, and probably the take-home message is that when you have critical stenosis with deep calcium, probably this is the best choice for prepare the plaques. In addition, when we are facing a bifurcation, lithotripsy permits to protect side branches, especially when we are talking about the left main. So that's all. Thank you for your attention.
Dear Chairman, thank you very much for the kind invitation. The title of my presentation is the usefulness of OCT-guided debarking in bifurcation. This is my disclosure. I would like to show 4 cases of debarking at bifurcation. The first case is calcium exists at opposite side of carina. The case is 71-year-old male, effort angina. You can see the severe stenosis in LAD and involving a diagonal branch in here. OCT shows at the opposite side of a diagonal branch, you can see the calcium in here. We have done a load ablation using a 2.0 mm bar like this. And then Zions stent 3.5, 23 implanted to the LAD and finished with KVT using a 3.5 and 2 mm balloon like this. Final angiogram showed a beautiful result. OCT show that this calcium is ablated by load ablation in here. After stenting, no carina shift happened and wide open of the stent. 1 year follow-up showed no restenosis. If there is a calcified plaque in the opposite side of carina shift may happen after stenting. Load ablation recommended before stenting. The second case is calcium occupies the orifice of side branch. This case is 70-year-old male, effort angina. You can see the calcium both sides of LAD and diagonal orifice. Load ablation was done in the 1.75 bar in the LAD, and then also load ablation to the diagonal branch orifice like this. OFDI show at the orifice of diagonal branch still occupies the calcium in here, but the lumen gain looks okay. So we implanted the result stent 2.75 30 into the LAD and finished with KVT. 1.5 years follow-up show no stenosis. If there is calcified plaque in side branch orifice, load ablation may help to result in single stenting without compromising side branch flow. The third case is eccentric calcium with severe tortuous bifurcation. This figure shows the left main trunk bifurcation with eccentric calcium severe tortuous LCX orifice. In this situation, load ablation with push force has a high risk for perforation. Orbital atherectomy, diamond back with pulling back has a less possibility of perforation. This case is 77-year-old male. You can see the calcium in both LAD and circumflex is very tortuous lesion. Also, this LMT severe stenosis was observed in here. And at the orifice of circumflex, also there is a severe stenosis. Using a glide assist, OA caster deeply into LCX and start pulling back ablation until LCX orifice. And then load ablation was done at the orifice of circumflex using a 2.25 mm bar. After circumflex balloon inflation, you can see the expansion in the circumflex orifice. And OAD show this is after orbital atherectomy low speed, ablation effect was observed in here, and high speed further ablation effect, and then rotablation 2.25 ablation effect was seen in here. And ballooning make a crack in there and wide open of circumflex orifice. For the left main tract LAD, this is a straight form of the vessel. So we have done the rotablation primary to the LMT to the LAD, and giant sky point 4.018 was implanted from LMT to the LAD, and across the guidewire to the circumflex, and the recrossing point looks okay. This is the stenting is here. And this is a LMT distal stenosis lesion. Rotablation effect was seen in here, and cutting make a crack in here, post stenting, and post cavity, you can see the wide open of a circumflex orifice. And 3D OFDI show wide open of a circumflex orifice. Final angiogram show good result. Circumflex orifice looks okay. For eccentric tortuous calcified lesion, pullback orbital atherectomy, diamond back may be effective to make an incision in calcified lesion. Aggressive following rotablation may lead to optimal lumen gain. The final case is abundant soft plaque occupied side branch orifice. 53-year-old male, at the orifice of LAD, severe stenosis, you can see. And at the orifice of LAD, diagonal branch and the high lateral branch and circumflex branch involved in the bifurcation. To avoid the LMT stenting, we have done a directional atherectomy using flex cut at the orifice of LAD, and the ablation effect looks okay. Then we implanted Ultimaster 418 at the orifice of LAD to the distal LAD. Final angiogram show beautiful result. And the follow-up angiogram show no stenosis. If there is soft plaque in osteo-LAD, directional atherectomy may prevent plaque shift into LMT and avoid LMT bifurcation stenting. Thank you for your attention. So first of all, I would like to say that OCT is a clear advantage to see the thickness of calcium and location of calcium. And also by OCT, we can imagine where to ablate by LOTA. Usually the adjacent area of caster is likely to ablate it. And Dr. Pan asked me about if the severe calcified disease and sometimes difficult pass through the OCT caster, we use a small balloon, non-compliant balloon inflation beforehand to go through the OCT and check the calcium disease, and we have done a lot of ablation. First, we try to pass through the OCT caster as possible before balloon inflation. But if it is impossible to go through the OCT caster, we use balloon inflation. Sometimes like an extension caster is helpful to pass through the OCT caster in the tight lesion, but some cases impossible to go through.
Dr. Shite, thank you very much, and it is great. And I know that OCT, and there is a masters of OCT and so on. But we also have experience with, I was like 25 years with OCT, 15 and more. And then when we do a lot of series of comparison, that we see that, of course, we can use OCT. And but sometimes maybe because of penetration, of light penetration inside, we can't see really maybe this vessel wall, I mean calcification. And for this reason, and then what we do, we use a coefficient, which is like we always know that it really depends on, but we know that with IVUS we can see maybe bigger dimensions, and then we ask them if we use any stent selection or cutting balloon selection and so on. And how you comment that, and maybe how you could recommend to use OCT, because sometimes for long calcified lesion we really can't see right dimensions, or maybe I'm wrong.
Yeah, as you mentioned, OCT has a limitation for penetration, but I think until the 5 millimeter or 6 millimeter, we can see it, right? So usually the LMT, less than 5 millimeter diameter, we can check it. And I think OCT has advantage over IVUS is the thickness of calcium we can see. And also OCT can see the vessel behind the calcium. IVUS cannot see the behind the calcium. So I think the calcified lesion, OCT has an advantage is the vessel size behind the calcium. So for me, the calcified bifurcation, we use most of the cases OCT. And also after implant stent, we can check the 3D OCT for stent configuration and see the guide wire recrossing position and open the side branch.
We do it a little bit different way, but I agree with you too. Yeah, that we can do it. Really depends on how we are skilled in imaging. But I completely agree what you said.
Yeah, and for left main trunk to visualize OCT image, sometimes need a technique to clear the blood completely. Sometimes difficult in LMT. But if you use like a 20 cc syringe with half contrast and inject maybe 3 seconds, 15 cc, you can get a clear image of OCT in LMT also. We have used Rotashock auto detection of calcium. This software is very useful to see the thickness of calcium and angle of calcium automatically, and also distribution of calcium in the longitudinal axis. However, still there is a mistake for calcium detection. A little bit sensitivity is low. So far, my eye is better than the Ultron software, I think. Sorry to say.
I like that very much, but maybe then I also bit to continue, because as I said, for example, in our and we did a lot of comparison, IVUS and OCT, and in different kind of, and also with BRSs. I mean, with where it is so important with BRS to really to try to modify calcium, and then after procedures, and after 1 year, 2 years, and 3 years, doesn't matter. But this is quite interesting, because what we usually do, we do IVUS before, because then we see, at least for left main, but I understand your point, better dimensions. And then the OCT we use, as you says, for something which is more inside the vessel. But doesn't matter which device we use or which method we use. Do you or what would be the percentage where you would recommend to use imaging for challenging lesions? It's not only a case about left main, but maybe bifurcations or even others.
Yeah, I use in Japan is a specific condition that all the image is reimbursed. So almost 90% we use imaging modality, and on maybe 70% of imaging modality we use OCT. But for generally speaking, left main trunk bifurcation and calcified disease, and also maybe the lung disease, difficult to measure the lesion length, I recommend to use OCT. 100% OCT, because we need a 3D OCT reconstruction to see the stent strut configuration. And to open the circumflex and LAD is very important, not like a diagonal LAD bifurcation, because this LMT bifurcation is related to the life prognosis. So we should get the optimal opening of this bifurcation lesion using OCT 3D.